If you ask women prior to the cesarean delivery what anesthetic outcomes they would most want to avoid, you get something looking like this. We asked women to both rank and put a relative dollar value towards potential outcomes, and pain during cesarean was the highest priority, and Lawrence has covered that very nicely in his talk. I'm going to be highlighting pain after the cesarean delivery. And I think it's important to consider this every time you induce a therapeutic option, because you may induce potential side effects, and there's always a balance between analgesic gains and the introduction of potential side effects, and we'll cover this as we go along. I have several learning objectives which are in your outline, and just a reminder that you have quite a thorough handout including all the references that I'll discuss, but I'm more than happy to share a PDF of my talk afterwards if you email me. So we'll be covering various multimodal analgesic options, talking about both the role of tap blocks and local wound infiltration, and a little discussion about breastfeeding in this particular setting. A few quick financial obligations. I have received money from Pacero, does a long-acting local anesthetic, and EKR, which promotes a long-acting opioid in the neuraxial space, and I will try and disclose any off-label use when I cover it. All right, so this is the slide to remember. Really, it's very much a multimodal approach towards this problem, and I'm going to cover each section in some detail. It's difficult to ascribe a particular pie size to each relative multimodal modality, but clearly the most important one would be a neuraxial opioid, and I'm going to start with that. There have been several studies. The graph highlights a study that Sheila Cohen did at our institution. When you think of an opioid, the best way of administering it, as you know, is neuraxially, not systemically. And in this particular study, they showed a good analgesic advantage in the first 24 hours. And this has been repeated in a number of studies. And you get anything from about 16 to 36 hours of analgesia following a single shot administration of neuraxial morphine. Morphine is the least lipophilic opioid we have available in a clinical setting, and it's going to have the longest duration of action because of the highest CNS bioavailability. And it's for that reason that it's very much the gold standard single shot opioid in the setting. And talking to North American audience, I know, because we've surveyed the SOAP audience, that the majority of you do utilize neuraxial morphine, but it's a surprise when you travel outside the US how this is still not caught on, and it's impossible to convince people that this is a very important therapeutic modality. Important when you are dosing to appreciate that there is an analgesic ceiling, and higher doses give you problems, in particular side effects of pruritus without obvious analgesic benefit. Craig Palmer did some work, and Lawrence briefly mentioned his studies, but these were dose-finding studies to try and see what's the optimal dose to utilize. And it's not just him who's tried to look at this. There are several other authors out there to try and pinpoint an ideal dose to use in a cesarean section population. And they've all pretty much failed to pinpoint an exact dose because of the variability in responses to neuraxial opioids. It leads to say that probably the dose range lies somewhere between 50 and 200, and it's probably up to you at your own institution to work out where that lies. In the last decade at Stanford, we've been bouncing between 100 and 200, and officially last week gave up and said we're using 150 and we'll follow Cynthia Wong, and she's been telling us that for the last decade, annoyingly. Should have listened to her. But anyway, the problem is if you go to the increasing doses, you do get subtle differences in improved pain, but you do introduce more side effects. You can give it intrathecal or epidurally. The vast majority of us in an elective setting are going to be using intrathecal. There's advantages because you're using smaller doses, so less maternal absorption of the morphine and less potential fetal effects, and it works a little quicker intrathecally. But if you look at post-operatively, epidural or intrathecal morphine gives you very similar analgesic and side effect profiles. There's 2 studies that looked into that. No significant differences there. As long as you account for equianalgesic differences, it's about 1 in 20. So a 100 microgram dose would be the equivalent of a 2 milligram dose epidurally. And similarly, the same analgesic ceilings that Craig Palmer showed in the intrathecal dosing, you show with the epidural dosing. Lawrence mentioned briefly about fentanyl and sufentanil role in intraoperatively, and that has been unequivocally well demonstrated. Not only do you decrease the pain during cesarean, if you look at meta-analysis, you can reduce patients' complaints from 24 to 4% by adding a lipophilic opioid like fentanyl or sufentanil, but there's a whole host of advantages intraoperatively. You can use less local anesthetics, so less hypotension, less nausea and vomiting, which is sort of counterintuitive that you're giving an opioid and you're decreasing nausea and vomiting. It's probably because of better afferent visceral inhibition from the pulling of the uterus that you are going to decrease that effect by having an opioid in there. You also can decrease shivering, both intrathecal and epidural administration, but you do pay the price of pruritus. We showed that you can actually increase your opioid requirements after cesarean delivery. So it's a misconception that by giving just fentanyl or sufentanil in your intrathecal space, you improve postoperative analgesia. We're not sure the mechanism. It could be purely acute tolerance, or the fact that if you use it in combination with morphine, you block the morphine from binding. But either way, this effect is very subtle. It doesn't offset the utilization of a lipophilic opioid, and the key reason for using the combination is that morphine can take up to 90 minutes to kick in, so it allows that transition to occur, and you'll have less patients complaining in recovery about pain. Similarly, it has an analgesic ceiling. Probably 20 is too high, and the optimal dose lies somewhere between 10 and 15 micrograms when used in combination with morphine for cesarean delivery. One slide just on extended release epidural morphine, because I appreciate it's not widely available. We have it on formulary, and we've studied it significantly in various settings. It is essentially morphine combined with a multivesicular liposome. The idea that you can extend it instead of just the first 24 hours into the next 48 or 72-hour effect. The problem with the agent is not only the cost, but you are then having to monitor patients for the 48-hour period. You clearly get better analgesia in the second 24 hours, and we've shown that in 3 studies that we've conducted. The biggest limitation for its use is that the majority of us use single-shot spinal for elective cesareans, and then in a setting where you have an epidural catheter, like in a labor setting that goes off to C-section, there is a potential interaction between local anesthetic and this liposome such that you lose a sustained effect, and clearly that's a problem both because of increased sudden release but also lack of efficacy. So this is something we reserve in select patients. I mentioned a little bit about the side effects, and Barbara touched on that, but pruritus is a nuisance. For sure, you've got to accept that you're going to make a lot of patients itch, and nalbuphine is probably the agent of choice in that setting, and naloxone if in small doses. One of the problems is we're not very sure of the mechanism. While it is likely mediated, there are other potential mechanisms. We know that it is definitely a centrally mediated phenomenon because methyl naltrexone, which we've recently studied, does not reliably decrease pruritus. You're going to induce nausea and vomiting in about 1/3 of patients, and the usual medications that you would use. Ondansetron's probably the equivalent 5-HT3s are likely the drug of choice in the setting, and it may have some antipruritic effect as well. The big concern why a lot of people are afraid of using intrathecal opioids is because of the respiratory depression, and for us that use it and have used it for ages, we really feel like it's really not a real issue. And one of the problems is that by not using it, you probably increase the chance of respiratory depression because you rely more on your systemic opioids. So the best thing to prevent respiratory depression is to give opioids in the most effective means we know, which is the neuraxial space. All right, there's clearly an over-reliance on opioids. The rest of the talk is really going to be focusing on other agents that we use to augment the effect of your neuraxial opioids. And pretty much every study that has looked at non-steroidals in the setting of cesarean delivery have shown a good analgesic advantage. The numbers needed to treat are around 2, which is in keeping with an opioid effect. You not only can decrease your pain, but you can reduce the amount of opioids you require. Meta-analysis estimate that to be around 30 to 50% dose reduction. And if you can use less opioids, you get less side effects. And from a maternal side effects profile, you're going to get less sedation, nausea, vomiting, and from a neonatal potential advantage of breastfeeding neonates, less absorption and less effects on that, which I'll discuss in a little while. And the key advantage of a non-steroidal in a cesarean section setting is that there's very little that gets through the breast milk. They're large molecules, highly protein bound, and the relative infant dose is extremely, extremely small, less than 1%. If you have patients who are unable to tolerate non-steroidals, celecoxib is a viable alternative. It has been studied in breastfeeding, shown to have similar transfer to a breastfeeding infant with a relative infant dose of 0.3. The concern with it is twofold. Although we have meta-analysis data in a perioperative setting that it works very well, and the efficacy is similar to non-steroidals, in a cesarean section model, we haven't studied it as well, and the studies that have looked at it, be it secondary outcomes, have shown it not to work as well. And I think one of the problems is for the numbers needed to treat to be in the same range as your non-steroidals, you have to do in the higher dosing range, so the 400 versus 200 to get that effect. Acetaminophen is also effective, but has a less of an effect on a non-steroidal, estimated opioid reduction of 10 to 20%. We all appreciate its synergistic effect with oral opioids, and recently meta-analysis showing us that it actually has an additive effect, so it shouldn't be used and/or with non-steroidals, but should be added to a non-steroidal regime. And with the IV preparation, it's made it that much easier to utilize. It does transfer a little bit more to the breastfeeding neonate, but very small amounts, still well under the 10 threshold that we start to concern about. And what we've recently shown is that it is better to give it as a regular medication for the first 2 or 3 days following cesarean rather than an as-needed basis. And the reason how we stumbled upon this is because our hospital was asking us to use no more than 3 grams maximum every 24-hour period because of the warnings that came from the manufacturers of acetaminophen. And in an attempt to do that, because we used to link it with Percocet or Vicodin, we decided to uncouple them and just use around-the-clock acetaminophen and allow oxycodone to be used for breakthrough pain. And we were able to reduce our oxycodone equivalent administration by 50% uncoupling the two. So my advice is for the first 24 hours to give regular around-the-clock acetaminophen and non-steroidals and use your opioids not as a combination of the acetaminophen, but as an individual dosing. We've largely moved away from intravenous PCAs following cesarean delivery. It's just not necessary. And as this study showed, actually the combination of oxycodone and acetaminophen is actually more effective rather than intravenous, both with reducing pain as well as having less side effects. So IV medication is reserved for patients not coping on our pain regimes, which is usually around 3% of patients that may require IV PCA. So that's the sort of gold standard of potential techniques that we could utilize, and I hope that everyone in the audience is utilizing combination with a neuraxial opioid, diclofenac, a non-steroidal, and acetaminophen. This combination, while it works very well, a group in the UK that looked at it, looking at the Royal College, which is very similar to JCO's criteria of pain score should be less than 3, show that only about 38% of women achieve this actual standard. So what do we say about this? Well, one of the things we can say is that it's a ridiculous standard and we should just sort of give up and not even bother anymore. Another approach is saying, well, maybe we can do better, especially with those patients who are a little in the outliers somewhere. So what are the other potential analgesic options? And the TAP block has all the potential to be the block for us because we know it gives good, reliable analgesia below the umbilicus, which is where our incisions are. It's sort of a block that was designed for cesarean deliveries in many ways. And there have been many studies and a lot of interest as to whether or not this block will work in the cesarean section population. And fortunately, we now have 2 meta-analyses to be able to pull the data, although there's still a few studies outside of this meta-analysis that are being published. But if you look on the left, the movement pain forest plot, and then the opioid use forest plot on the right, I'll break down the 3 areas. The first one is institutions that do not use intrathecal morphine. And there it is clearly been shown to be beneficial, a tap block. So if you do not use intrathecal morphine, you have reasons, institutional factors, then it is worthwhile considering tap blocks in all your patients. If you do use intrathecal morphine, the 2 studies that looked into it did not find the tap blocks added much to it. There is a recent study that showed that it does, but combined effect is showing us that it's not adding much analgesia, perhaps in the first 6 hours after cesarean delivery, but not much more. If you compare tap blocks to intrathecal morphine, so as an alternative to intrathecal morphine, it doesn't do as well, and there's several studies in the forest plot showing that it didn't favors intrathecal morphine. So that's where we are when it comes to tap blocks for cesarean delivery. So just to summarize, you can use it routinely if you do not use intrathecal morphine. There's good evidence for that. If you do use intrathecal morphine, then likely its utility is for select patients. I've given a selection of things that I think would be beneficial in patients where you can't usually use your treatment protocols. In our institution, the main use that we have is for rescue blocks. So these are patients who in either recovery or on the floor are not doing as well, and rather than accelerating their intravenous opioid utilization, we get their pain under control with a tap block as a rescue block. We've published some evidence how effective it can be. One of the problems with tap blocks is you're always going to struggle with is that a lot of the pain is visceral pain. It is not from the incision site necessarily, and obviously tap blocks only deal with the incisional site. And its duration of action, unless you use catheters, and although there's a small case series of the utility of catheters in the cesarean section setting, not that easy to manage, and the single shot blocks are not going to give you significant analgesia beyond 6 to 12 hours. Local wound infiltration used to be ubiquitous in all surgeries. As we move from general anesthesia to a spinal anesthesia for cesarean, we've largely abandoned that, and there's evidence to say it doesn't work very well when we're doing cesareans under spinal compared to a general anesthetic. Extended release epidural bupivacain's role may show to have some benefit, but the studies are not there, and I don't expect to adopt it until there's evidence for the extended release of the bupivacaine. But we do have continuous wound catheters, and there are a number of studies showing that it is beneficial. These are wound catheters, and there's several disposable manufacturers where you can bury it under the wound or subfascially to provide analgesia following cesarean delivery. What we do know is that it decreases opioid use, and it improves pain, in particular the pain at movement, that incisional pain. We know that you need higher rates for it to work well, not just the slow trickle, and the problem with that is wound leakage, and the OBs and patients hate it. And one of the best ways of utilizing this is to get the surgeon to bury it subfascially. And study out of France showing convincingly that you're going to get better analgesia if you put it below the fascia than above the fascia. And this is based on not only this study, but evidence from the hernia surgery work. And the reason probably for that is that you are blocking the perforating nerves that go through the rectus sheath to the anterior abdominal wall. Another reason may be that in particular this study, they left the peritoneum open, so you're getting local spreading into the peritoneal cavity, because there is evidence that intraperitoneal lidocaine works, and maybe it works because it's numbing up the uterus, but it could work purely from a systemic absorption point of view, because there are several studies showing that just intravenous lidocaine has not only analgesic effects, but can improve functional recovery and discharge, not in the cesarean section population, but in other surgical models. Now, while I'm saying bury the catheter subfascially, I'll just divert off with a off-license use of drugs, but there is growing work showing that particular incisional site administration of drugs may be more beneficial than systemic administration of drugs. The first study on the left is Patricia van der Hoem's work, and a summary of it, the dark line in the bottom, is basically diclofenac given within the wound. The line above it was systemic diclofenac, even with the wound local anesthetic, and the one above is just systemic diclofenac. So it seems like you have a better effect by giving a non-steroidal within the wound, and we know that that's the site of injury as well as pain potentiation, so it makes some inherent sense. The problem with that study was there may have been a pharmacokinetic effect because they were using the same dose. We decided to see if it actually had a local effect. So the graph on the right is using a tiny bit of Toradol, so it's 30 units over a 48-hour period in the wound, and that had an analgesic advantage as well as an inflammatory advantage over just the bupivacaine. So I think you'll start seeing this development of multimodal wound analgesia in the coming years. But what we can use now, which is readily available, is gabapentin. And initially we were very encouraged by Jose Carvalho's work in Toronto showing that 600 milligrams significantly decreased acute pain, and there's a graph of that, fairly significant analgesic effects. But they extended that study, and then we're looking at a dose range study, 300 versus 600 versus placebo, and unfortunately the repeat study showed no benefit. So we're sort of stuck with what do we do with gabapentin. And there are concerns with gabapentin. We know it works really well as a perioperative analgesic, but as a preemptive agent, and we do not want to give this agent preemptively because of a very high transfer to the baby, and this is a neurotrophic drug. We know it works within the brain. And there is some concern of breast milk transfer because this drug has a tendency to cause sedation and may impact negatively. So we're stuck with a drug that may be beneficial, certainly is not there for routine use, but it is indicated in patients who are struggling to manage pain afterwards. For sure, it would be my first go-to oral agent. Dexamethasone is an agent you don't normally associate with it as an analgesic, but there is actually very good evidence for its analgesic efficacy. A recent meta-analysis of 45 studies, so it's fairly well studied. This is outside the cesarean section population, showing a good analgesic benefit, 2 out of 10 reduction in pain score, weighted mean difference of morphine of 22 milligrams, and the concern that it's going to have wound issues or delayed wound healing or infection have not been realized within the meta-analysis of just under 6,000 patients. But it is still a little bit of a concern, and it does increase blood glucose. In the studies that I've looked at for the C-section population, I've cited 2 there using a 10 milligram dose. As you would expect, decreased nausea and vomiting and subtle differences in pain scores. So yet again, an agent that you may consider in some patients. I don't think it's a drug that has utility in all patients. And ketamine, well, ketamine is an agent that we've had around for a long time. It's an NMDA antagonist, and more recently it's been shown to actually have anti-inflammatory activities. And meta-analysis in the population outside the cesarean delivery show that it is a very good agent in sub-anesthetic doses. So these are small doses, the 10 to 15 milligram doses around surgical time, shows that you can actually get analgesic benefit for 24 hours following surgery. In the cesarean section population, the efficacy is a little bit more contentious. So it's been shown to be effective if given for a general anesthetic. This is small doses, once again, so not induction doses, but just a small analgesic dose. And it's been shown to be effective for spinal anesthesia, but without the whole multimodal analgesia we use. Cynthia Wong's group looked at it and found it not effective when you add it to the treatment protocols we've discussed, the non-steroidals, acetaminophen, and neuraxial opioids. It may be a dose effect. It may more be something of how long you have to give the agent. A study coming out of Italy showing as a continuous infusion, and not only improved pain, but it decreased wound hyperalgesia, which would suggest that especially in patients who are high risk for chronic pain issues, that this may be an agent that you would consider. And one of the big problems with ketamine is it has to be an agent that you target individual high-risk patients, because as Carolyn mentioned, a lot of these drugs have potential neonatal effects. And when you're giving the agent in this setting, either before the baby's born or in breastfeeding babies, there is potential transfer to the neonate. And all agents that have anesthetic properties, and actually the worst of it being the NMDA antagonist, show widespread apoptosis after administration. And if you extrapolate the animal data to the human data, that means the developing brain, the most rapidly developing brain, is going to be more likely to have apoptotic changes after 6 months of gestation to the first few years of life. So this is a key period that you want to avoid these agents. And while we haven't clearly demonstrated in humans It's not a social experiment we want to do by giving all of our cesarean section patients ketamine. There may be a healthier NMDA antagonist option, and Cynthia mentioned intravenous magnesium. A recent meta-analysis, another forest plot to show you, with decreasing both pain and opioid use. The effect size was small, but at least this is an agent that would be a healthy alternative than ketamine, and it's something we may see more use of in the future. So this is the Stanford protocol. I've still got 5 minutes more on my talk, and I'm actually going to talk a little bit about some breastfeeding considerations in those. But in summary, we use a 12 milligram bupivacaine dose of hyperbaric bupivacaine. We want to give a dose that's going to be guaranteed to give good surgical anesthesia, and that's the dose we came across with our dose-finding studies. Fentanyl in the range of 10 to 15, and morphine, like I said, intrathecally 150, or the equivalent if you're giving it epidurally. We give around-the-clock ibuprofen and acetaminophen. We allow intravenous acetaminophen for patients in PACU as well as patients not taking orally. And then we use oxycodone for breakthrough pain, 5 to 10 milligrams as needed. Like I mentioned, intravenous morphine or the equivalent opioids for a PCA is utilized in very few patients, in patients we're not managing very well. We may consider fentanyl boluses. There's some advantages, and I'll show you in the breastfeeding literature. And then we have a few other analgesic options in patients we consider at risk or difficult to manage or previous bad experiences, with extended release epidural morphine. Chronic pain patients, we would utilize continuous catheters for the first 2 days. Tap blocks are an option, wound infiltration, and like I mentioned, gabapentin, dexamethasone, and ketamine on an individual need-to-need basis. All right, so to end off in a few slides, I want to quickly show you some breastfeeding measurements and concerns, because what separates this particular surgical model is that you are dealing with women who are not only undergone surgery, but are going to be breastfeeding, and there's going to be transfer of analgesics to the breast milk. So we know that over 70% of patients now, because of the increasing rates of peripartum breastfeeding, are going to be breastfeeding, and we know that all analgesics will transfer into the breast milk. So before you prescribe a drug, you should have some appreciation for what's going to be happening potentially. And I don't want to put you off giving analgesics, because that graph on the right actually was comparing 2 different analgesic regimes, but the short of it is patients with better analgesia breastfed better, and you actually had better growth in the neonate. So good analgesia is an important impact on breastfeeding. Now, I said I'll only give you a few slides, but I didn't say how busy the slides would be. So I'm going to try and summarize everything you sort of need to know when you're thinking about giving a drug and the potential breastfeeding effects in one slide. So what we really want to know is what concentration of drug is in that breast milk. And the best way of knowing that is thinking, what is maternal drug level? Because how it really works is it's just a membrane that's going to, based on the level in the mom, is going to transfer to the breast. It's not like you give a drug and then it goes straight to the breast and just stays there. So the breast milk is going to be very much dependent on maternal drug level. There is an MP ratio, which is how the affinity of the drug to go into the breast milk, but most drugs, especially the ones we use, follow just a pure diffusion gradient down that. So don't worry so much about MP gradients. It's focus on what is the mom's level at the time she's going to be breastfeeding. And how do you work that out? You work it out by what drug she got, how long it lasts, what dose, what route of administration, was it intravenous large dose or a tiny dose spinally. And if you can work that out, you're 9/10 the way of working out how much the baby's going to be exposed to. But there are other considerations. The next consideration is the bioavailability of the drug. So if the drug is in the breast milk but can't be absorbed by the baby, well, there's no issue that's going to occur there. And then the volume that's being consumed. And the one advantage we have early on is, especially in the first 2 days of life, there's small amounts of colostrum and not large amounts that are being taken in. So analgesics become a bigger issue on day 2, 3, 4, and beyond. And we talk of absolute infant dose and relative infant dose. I've been keep going on about the relative infant dose, but it's basically of the drug that the mom got, relatively how much has the baby got, because babies don't do as well handling drugs. The capacity to handle drugs, both because of renal function as well as hepatic function, is about 1/3 the adult. That's why we always think of 10% relative infant dose. And the good news is all the drugs that we think about have relatively low relative infant dose, the opioids probably being the big culprits. So if you're going to make any impact, minimize the amount of opioids you give. But all of them are way below the threshold of 10 that we're most concerned about. But very briefly, when it comes to non-steroidals, my advice to you is use agents with the shortest half-life that have been around for the longest time. Ibuprofen is probably the best drug. It's compatible with the American Academy of Pediatrics and the Academy of Breastfeeding Medicine. Toradol, ignore the black box warning. We use it. It's probably a very good drug. The longer acting drugs may be problematic. There's a few case reports of that. When it comes to opioids, consider the dose and consider the route of administration. Use the most effective route of administration, obviously spinally. Fentanyl is probably the drug of choice as a PCA if you're using large volumes of it, but morphine is a perfectly good alternative. It has a low bioavailability, so although a lot of it does get into the breast milk, less gets absorbed. And most of the other oral opioids we use are reasonable. The drugs to avoid are meperidine. It has extremely long half-life and neurobehavioral effects for long. The buprenorphine, probably because of the kappa effect, and has been shown to show dysphoria and suppression of breastfeeding in the studies that have looked at it. And codeine is the one recently that got the bad rap because of the Lancet case report of fetal harm. It's a prodrug, and a mother that was a rapid acylator and metabolizer of that, and they believe it may have led to fetal harm and death, although that has been questioned. So that's it in a nutshell, and that's our approach. I hope it's been useful to your own practice.